So, good afternoon and welcome. My name is Gavin Yamey. I'm a professor of global health here at DGHI and a professor of public policy over in the Sanford School of Public Policy. Thank you so much for registering online for this event today. And also thank you for your flexibility in shifting to a virtual only format because of the snowstorm. Our kid is hoping to do some sledding later. As am I, fingers crossed. So Dr. Jonathan Quick, aka Jono, is going to be moderating the panel and introducing the speakers, but he very kindly asked me to just say a few quick opening remarks. And really, the most important thing that I want to say is this, that the center that I'm very lucky to lead, the Center for Policy Impact in Global Health here in DGHI, is really honored and delighted to host an extraordinarily exciting and important new initiative on market-driven epidemics, MDEs, which is the topic of today's panel. And I think it's pretty unique, I believe, to have a university-based research enterprise that's shining a light on these market-driven epidemics. And there's no doubt in my mind that the time is right for such an enterprise. The unhealthy use of consumer products like tobacco, sugary and ultra-processed foods, prescription opioids, firearms, and so on, they contribute to an estimated 1 million deaths every year in the US and at least 23 million deaths annually worldwide. These products, of course, contribute to heart disease, obesity, diabetes, cancers, substance misuse, and they cost economies and health systems trillions of dollars. And this new MDEs initiative, based in the Center for Policy Impact in Global Health, is going to address a really crucial question. What does it take to significantly and sustainably bend downward the epidemic curves of unhealthy product use and the consequent harms? The MDEs initiative here at Duke is going to be action-oriented. It's very much aimed at shaping policies to avert illness and death. And so congratulations to Jono and to MDEs team member Esther Romagni on launching this new initiative. And with that, I'm going to pass the mic over to Jono.
Great. Thanks very much, Gavin. Good morning to everybody. I'm Jono Quick. I really appreciate the kind words and also the support. These are the kind of issues which sometimes are left homeless. But as Gavin pointed out, I mean, this really is a major challenge. It's something that back in 2018, when I had just been spending the year launching a book, The End of Epidemics, The Looming Threat to Humanity, on one sort of recurrent pattern of illness, I started thinking about another recurrent pattern, which is this pattern of there's a product that is developed or discovered. Companies see that there's a felt need here, and they said, you know, we can start selling this. So they sell a whole lot of it, and then the public health people or student clinicians say, you know, this thing that the humans like is killing a few people. So then we do the science. So then the companies say, these scientists are going to kill the golden goose. So they buy up other scientists. And we spend decades, as Esther will show you, literally decades. So it was an idea until an undergraduate at UNC reached out, Esther Romagni, and said, I'd like to explore this. And this has been an incredible journey over the last 4 years. So I think it's pretty clear that more and more the death certificate may read cancer, heart attack, diabetes, obesity, suicide, murder, but the root causes are market-driven epidemics where companies have mastered the science of hijacking our brain's pleasure center, and we'll hear about that from Professor Lemke, They really excel at marketing, Marlboro Man, Virginia Slims, and all that. Um, they also work really hard to resist claims of product harm and all. So that's the essence of what we're looking at here. So let me just share a few slides by way of kicking us off here. So yes, this is the core question. Now, many of you are familiar with the concept of commercial determinants of health, a term coined about now 20 years ago by a WHO colleague, but something that's gotten a lot of traction. Market-driven epidemics, that methodology we see as a unique dynamic within the broader commercial determinants of health area. So if you're going to have an epidemic, you got to have a case definition. And this is the article that came out July last year. It's basically the defining article where we lay out a case definition for market-driven epidemics. And I think this is the academic version of my opening comments. So we've actually laid some good groundwork with publications, that initial one, some spin-off ones on social media. And then what was fascinating was the outreach from different members of the community that is thought of as commercial determinants of health. So we have three epidemics, three pieces of work in progress, and some nice media coverage that we've been able to get with time and some others. And you can see there's a web page there on the department's website. So we're really lucky today to have some of the folks that have just been groundbreakers in this area. And here's the game plan between now and the time we head off at 1. So let me turn first to Esther Romagné, who is a chronic disease epidemiologist, as I mentioned, recent grad from UNC. And she was the lead author on that field defining paper. And I can tell you, she was a model of persistence. We started with one high-profile global health journal, and they said no. They didn't disclose that they were actually doing a bunch of related articles in any case. And then we turned to the next through PLOS Global Public Health, and really had quite an adventure with 2 rounds of revision, and they really helped shape it. And it was a great partnership and a great dynamic. But that took a whole lot of persistence when we got the reviews back. So she's also managed a group of international authors. All of the papers have a lead or leading person who's a student, but also who has earned that role, but also we pull in co-authors from around the world. So Esther, over to you on some of the insights from that first groundbreaking paper.
Thank you so much, Dr. Quick. Let me share my screen.
What?
Awesome. So I'm going to be talking about market-driven epidemics today, specifically the five-phase framework. I'm going to go over the arcs of the epidemics of tobacco, opioids, and sugar, and then mention some of the lessons from the effective mitigation. So you don't have to read all the words on this slide, but these are the 5 phases that we found. As we interrogated the data of tobacco, opioids, and sugar, we found that similar to infectious epidemics, commercial epidemics of origin also go through predictable narrative stages. And we coined those as market development, evidence of harm, corporate resistance, mitigation, market adaptation. What do these mean? Well, market development's just the first phase that encompasses when a highly desirable product is made, usually through innovation or slight tweaking of something that's already existing. Then aggressive marketing really ramps up product consumption. There's different techniques to this. I'll go over some of them for tobacco, but increase in appeal, social desirability, and addictiveness are some of them. Evidence of harm is the phase that really concerns scientists and researchers, that goes from an inkling of some type of pattern going on with a specific product to a rigorous confirmation through research that yes, this product is harmful. Corporate resistance is the response to this suspicion or confirmation of harm from the companies, where they deny that their product is harmful at all, and they have many tactics of this. Hopefully, Dr. Lemke will go into some detail on this, which will be really interesting on opioids. And in this meantime, deaths and illnesses and economic impacts accumulate. Mitigation begins with usually one watershed moment, but is really a synergistic, sustained action from multiple actors that consistently drives down the product consumption. Market adaptation is the response to this by the consumers, but also the companies. And we'll go into depth on that with tobacco, but this is the overview. So to discuss all of this, I think tobacco is a really good example to look at this concept of 5 phases with the data, because it's perhaps the original market-driven epidemic. A lot of the later market-driven epidemics take a lot of the corporate ideas that tobacco industries used and mimic that in their own epidemics later. Also, this is the one that has run the most course and has kind of completed the entire 5 arc of the MDEs the best. So we start in the early 20th century. The James Buck Duke industry, actually, or company at Duke University, who's the namesake of Duke University, commercializes cigarettes with a machine instead of hand rolling, and using many different marketing techniques. For example, marketing specifically to women, saying that cigarettes used to be a manly behavior, so using the suffragette movement, showing that women can also smoke, or marketing specifically to Black Americans through things like jazz concerts or in barbershops, or marketing specifically to white men with ideas of this rugged cowboy. Basically using marketing strategies that create these niches of market groups to market to. Then also they do things with the social acceptability, as provide cigarettes as part of the US ration to soldiers when they go to World War I and II, which again creates a huge new population that used to not be smokers into now smokers. So as we can see over the first half of the 20th century, with all of these marketing techniques, use of cigarettes skyrockets. What is science doing in the meantime? Well, we have our first long suspicion of harm. It's a 400-page letter graph, essentially, from a doctor, looking at a lot of different evidence, not really harsh, rigorous science, but ideas, rather, gathering of ideas of what cigarettes may be. Prior to this, cigarettes and tobacco in general was considered perhaps a medicinal herb. So the idea that cigarettes could cause harm was kind of new, and they gathered all of that evidence into like a 400-page book. But as you look at the data here, as you look at the curve here and where I put some of the milestones of an MDE, I don't know if you can see my cursor, but the rigorous confirmation of harm came 4 decades later. Part of this is because epidemiological tools were not yet developed, and science kind of developed as the cigarette epidemic was happening. But there is a big argument to be made that perhaps we could lessen this this gap in which a lot of the cigarette use came up. The next milestone is the consumption tipping point. And you can also ask a question, well, if we already have science determining that cigarettes are harmful, why did it take 10 years for consumption to decrease? What happened? So in this time, the Surgeon General's report came out in 1964 at a very good time in mid-January. There's no holidays going on to take up journal space. They published it on the Sunday, which is perfect then for newspapers to cover it on Monday, and everybody was talking about it at work. And they unequivocally said that cigarettes cause lung cancer and cigarettes are harmful to health. Before this, cigarettes were more viewed as a pleasurable product with little to no side effects. But now this is a very clear stance from the government that no cigarettes cause lung cancer. And this basically shifted consumer behavior. Well, I didn't put them on this graph. Then there's many different actions from federal level to state level to grassroots to legal that all continually drive down the consumption. So while we have this one catalyst event in 1964. There's many, many events after that keep the trend decreasing. And as you can see, with the number of lung cancer deaths with a 20-year shift because of the amount of time for lung cancer to come out, we can see that the harm curve follows exactly the consumption curve. So what does this curve look like for prescription opioids and sugar? We can see that we still have this increase, one watershed moment, and then, at least in consumption, a sustained decrease. What happened for this watershed moment for opioids and sugar are very interesting. So for prescription opioids, the CDC has this declaration that the reason why so many people are overdosing on opioids is not because people are misusing them particularly, it's because of the amount of overprescribing by physicians. Before, the physicians mainly taught, although I'd love to hear Dr. Lemke's takes on this, it seemed like there was an idea that the amount of overdoses came from misuse rather than perhaps an over amount of given of prescription opioids to US patients. But once the CDC communicated to the physicians, which were the level that decided the amount of consumption, not the consumers in this case, then people started prescribing less levels of opioids, and then consumption decreased. So it's again a very authoritative, clear public health voice communicating health information. In sugar, this happened similarly, but if you look at the graph, it's actually interesting. It happened before confirmation of harm. But a lot of people in public health, different organizations, different sugar and cardiovascular disease researchers, some obesity researchers came together and had this petition that was very high in public view that said that the amount of sugar that Americans are consuming is leading to an obesity epidemic. Again, a very clear, authoritative public health voice community came together and communicated this unequivocally, and people turned their behavior around. So when we look at these three watershed moments, and then we can look at some of the other ones that kind of continued this trend, we can look at how authoritative public health voices, when communicating information directly and effectively, can have a very big impact on individual level consumer behavior. All right, so what's the point of this MD framework? What's the point of the 5 phases? What does this add to commercial determinants of health? Well, one, we can look at how, using these ideas, we could bend the curve in epidemics where they haven't been bent so far. So the takeaways from the mitigative actions that I talked about, those are some of the big ahas that we could perhaps lift over to other epidemics where the deaths haven't decreased, like guns or others that we can talk about today. The second big aha is the idea of quickening the time between phases. If you remember back to my tobacco graph, here, what could have science done to make the time between suspicion of harm and confirmation of harm less than 4 decades? And the amount of consumption that happened in that time, I mean, the deaths that it led to, as you can see on this upcoming paper that I'm working on with Dr. Quick and some others, the amount of difference in just a 5-year reduction could have saved almost 2 million lives. If you go down to 15 years, we could have saved almost half of the lives or more. So if we can try to shorten the amount of time between phases, look at in the past, what were the key events that kind of brought along the MDE to its next phase, we could skip out some of that time and that lag in between, and that could lead to potentially the potential life saved in millions. So that's the real big aha of this 5-phase framework, and I'd love to pass it on. Thank you.
Yeah, thank you, Esther. And it's clear that the efforts that were made in those 3 areas changed the behavior of millions of Americans. Anna Lemke is professor and medical director of the Addiction Medicine Center at Stanford, and her book, Drug Dealer MD, How Doctors Were Duped, Patients Got Hooked, and Why It's So Hard to Stop, and her follow-on book, Dopamine Nation, Finding Balance in the Age of Indulgence, will give you a sense of what she's talking about. And to give you a vivid sense of how much the Dopamine Nation resonated, you'll find close to 10,000 reviews on Amazon, and it's been translated into 30 languages. So those of you who are interested in what you could do about market-driven epidemics, and as a great person. So, what is compulsive overconsumption, and what are companies doing to hook us and undermine our science, Anna?
Thank you, Jono and Esther and my fellow panelists and Gavin for inviting me. I'm excited to be here. What I'd like to do is just drill down on one very important concept in how corporations contribute to these market-driven epidemics. And that is that they take a product that has been known in many cases for centuries to be highly addictive, and they promote it as not addictive. And just to define terms, addiction is the continued compulsive use of a substance or a behavior despite harm to self and or others. We don't have a brain scan or blood test to diagnose addiction, but we nonetheless do know that it is a brain disease characterized by classic physiologic and anatomical rewiring of the brain. And things that are addictive are typically things that mimic a chemical our brain already makes, but in super potent forms, thereby releasing a lot of dopamine all at once in our brain's reward pathway, dopamine being our reward neurotransmitter, which has come to be a kind of common currency for how neuroscientists measure the addictive potential of a substance or behavior. The more dopamine that is released in response to a stimulus, and the faster that it's released, the more likely that substance or behavior is to be addictive. So somebody put in the question, or actually a comment or a suggestion, which I thought was very clever, which was instead of calling it market-driven epidemics, and the acronym should be market developed. Actually, I'm going to look here again. What was it? It was a clever. The acronym should be market-driven epidemics. Oh yes, that's what it is. As in made, M-A-D-E, as in humans made it, which I think is a really important point, because through the application of science and technology, we have taken, in many instances, natural plant-based products and created super potent forms of them, which release a lot of dopamine all at once, which make these kind of natural rewards even more addictive. Okay, so what are these companies doing to convince the public, and also more importantly, the medical community, that these products are not addictive? They use a number of very clever strategies. And the first is something I'm going to call set and setting. For those of you familiar with psychedelics, that will be a familiar term. But essentially, the idea is that they tell prescribers that as long as the patient is getting the substance, for example, an opioid, in a medical setting for a medical condition, that patient is somehow immune to the addictive potential of that drug. Now, opioids bind to opioid receptors in the brain. They produce analgesia, so they are pain relievers short term, but they also release dopamine in the brain's reward pathway. So they have a dual function, and they are highly addictive. And it is in fact untrue that if a patient receives their opioid for a pain condition in a medical setting, that they'll be less vulnerable to addiction. That is simply factually not true. We have had evidence for more than a century that that is not true. The narcomania of the early 1900s was essentially, the nexus of that was essentially doctors prescribing opium and heroin, which is just opioid or opium or morphine with two acetyl groups added. Those were the soldiers and the young men and the babies who were getting tinctures, who were getting addicted. So we already knew that set and setting did not make patients immune. The industry went also so far as to say that there was actually some kind of biological difference between a person with pain and a person who would become addicted, such that the opioid wouldn't work on the reward pathway in the same way, and hence would not be addictive in a pain patient. Again, we knew all of that, but beforehand that wasn't true, and there's been just a wealth of evidence since the opioid epidemic, again corroborating that idea. The other thing that the industry did was they took short-term studies on opioids. For example, typical studies showing analgesia or pain relief over a 2-week duration, and they use that as evidence for long-term use. And the reason that this is really insidious and pernicious is because the longer you take an addictive substance, the more you alter your brain and the more you are likely to become addicted to that substance. So the evidence that we have for opioids is for short-term efficacy on the order of 2 to 4 weeks. There are no robust clinical trials showing that opioids taken for longer than 4 weeks are effective for chronic pain, and not importantly more effective than non-opioid analgesia like ibuprofen and Tylenol, which have far fewer side effects and are not addictive. So this idea of using duration or a data point for short duration and then applying it to a long-term duration, and then the opioid manufacturers and the industry more broadly also promoted long-term use at high doses, which is how we ended up with a generation of patients taking very high dose opioids for very long periods of time and becoming dependent and in some cases addicted. Now, I want to emphasize that not everybody who is exposed to an addictive substance will become addicted to that substance. That's as true for opioids as it is for alcohol, as it is for whatever addictive substance or behavior you come up with. But there will always be, and has always been, a subset of the population, approximately 10 to 20% of humans, who are more vulnerable to addiction and who will become addicted even with very short-term exposure. The other thing that corporations did was perpetuate or invent and disseminate concepts like pseudo-addiction. So pseudo-addiction was a made-up term that was then disseminated by the opioid industry that taught doctors that if you notice signs and symptoms of addictive behavior in your patient, they're not really addicted, they're pseudo-addicted and in pain, and what you need to do is to increase the dose. And that kind of mythology made it very difficult for physicians to identify and name opioid addiction even when it was present. And Esther, just to respond to your query, was it a misuse problem or was it a supply problem? It was all of that and more. It was also a huge diversion problem. So starting in the late 1990s, doctors, because they were convinced by the industry that opioids were not addictive as long as they were prescribing them to patients in pain, started increasing their prescriptions for opioids, prescribing higher doses, longer duration. That continued until about 2012. And in lockstep with increased prescribing, we saw an increase in opioid overdose-related deaths and an increase in cases of opioid addiction. Since the decrease in opioid prescribing, it has taken a long time for opioid-related deaths to go down, primarily because people who couldn't get prescription opioids then transitioned to illicit opioids, primarily illicit pills, some laced with fentanyl, illicit heroin, and of course now a whole generation actually going to illicit fentanyl as a first-line product, fentanyl being a much more potent opioid than really anything else on the market. I want to highlight that one of the ways in which the industry was able to disseminate these false ideas about the non-addictive nature of opioids was to really infiltrate medical education, like continuing medical education offerings that physicians are required to attend to maintain their license, by systematically ignoring harms in their publications of articles, and by highlighting spurious data points, things like the Porter and Jick level. In conclusion, I just want to highlight that the advertising of a known addictive substance as a non-addictive medicine is not unique to the opioid epidemic. The same thing has happened with cannabis. Cannabis has been heavily marketed as a non-harmful treatment for many different physical and mental health conditions. And it was so successful in that marketing that there are many highly educated people who believe that cannabis is not addictive. In fact, we have had for many decades plenty of evidence that cannabis is highly addictive. And now with the super potent forms that we're seeing more and more harm related to cannabis. I will also want to emphasize that the same thing is happening now with psychedelics. Psychedelics work primarily on our serotonergic system, but they're also reinforcing, they're also addictive. But if you ask the average person, they will say, who has read up on this in the lay press or maybe even in academic journals, they have learned or have been taught that psychedelics are not addictive. And the same phenomenon of set and setting is being parlayed here in the movement to make psychedelics broadly available for mental health conditions, including by putting out the myth that if a doctor is prescribing it in a medical setting for a patient who has depression, then the patient's not vulnerable to getting addicted to it. And that's simply not true. We don't have any evidence to support that. There's growing evidence to the contrary. So I'll end there. Thank you so much.
Wonderful. Thank you, Anna. And that's and lots more. I really would commend for anybody who wants part two, which is how do you apply some of the insights to controlling any kind of overcompulsive consumption you have. Dopamine Nation is a great next step on that. So we've been through three of the kind of some of the most commonly known market-driven epidemics, but we're going to shift now to a quite a different one, and we're really lucky to have somebody from in-house from Duke Global Health Institute, Anjali Palmquist, and this is the epidemic around misuse, misrepresentation, mismarketing of infant formula, which goes by different names: breast milk substitute, commercial milk formula. And so Anjali comes with cultural anthropology skills, and that, for those of you Duke folks who remember the late Paul Farmer, it was his anthropology skills which really helped the impact. And so we're very fortunate to have Anjali with us today to talk about this other kind of market-driven epidemic. Anjali, over to you.
Thank you so much, Jana. I am really excited to be part of this panel. I appreciate this opportunity. So I'm going to just talk a little bit about how the history of marketing of what the WHO has called breast milk substitutes, which has now shifted to commercially marketed formula, or baby formula, baby milk, infant formula, and just illustrate how some of the analysis of the ways that it has been marketed over time really does map to a market-driven economy evolution, and also to think about how this methodology may lead us to a place where we can disrupt some of the harms that are being driven by this epidemic. So actually the development of shelf-stable infant formula that could be marketed commercially has a similar timing history as the marketing of tobacco. And so the strategies of marketing tobacco and infant formula have very much a similar playbook. It was around 1974, almost 100 years after it had been invented, that an international NGO began to do some investigative reporting to really understand what they were seeing in primarily sub-Saharan African countries, of the massive numbers of infant deaths associated with bottle feeding with different kinds of breast milk substitutes, but including breast milk powdered infant formulas. And so one of the key historical milestones was their publication called The Baby Killer, where they documented specifically some of the marketing tactics that were being used, not to generate an addiction, however, but to generate a physiological dependency. So disrupting lactation among breastfeeding mothers and pushing substitutes and dependencies on these commercially available infant formulas as a way to feed infants, which was resulting in excess death. One of the things that this report also documented were some of the marketing tactics that companies like Nestle at the time were employing. And this included providing some of the salespeople who are introducing these products into new markets across the global South as healthcare providers. So you have the very famous quote unquote Nestle nurses who would introduce products to breastfeeding mothers and let them know that it was a healthier alternative for their babies, giving them free samples, just enough time for there to be a disruption in lactation physiology so that if a mother decided she no longer wanted to use the formula, or if the formula ran out when it did, that they would not be able to produce more milk and would be sort of dependent on trying to find other means to get their formula. So this is a photograph of both the report on the war on want and then a photograph of a very wasted young infant. In the literature between the 1930s and the 1970s, there's a number of nutritional reports that were being published with similar kinds of images of wasted and stunted infants that were being bottle fed. So we have this emerging evidence that there is harm. This led to the first major global boycott of Nestle formula. And one of the international nutritionists who is publishing a lot of this work based on his work internationally was Derek Joliffe and his wife. And he is the first to coin this notion of a commerciogenic malnutrition problem. And in one of his articles saying that the infant food industry must bear a considerable burden of blame as a result of unethical advertising. So we see here not just a recognition that bottle feeding and this formula that was being sort of peddled across the world, but it was being marketed in really particular ways that was behind some of the harmful effects that we were seeing globally. This led then to a global contingency led by many leaders of African countries, along with other international leaders, who put together what we now call the WHO Code, or the International Code of Marketing of Breast Milk Substitutes. It was taken to the World Health Assembly in 1981 and adopted. 118 countries voted in favor of this code. There were 3 abstentions, and the United States casted the only opposing vote and has never supported the WHO code. As we understand all of these codes and these World Health Assembly resolutions, there have been subsequent resolutions since 1981, but it really is a guide, sort of a framework and a tool that countries can use to implement policies, and then other kinds of regulations, laws, and so forth in their own countries to uphold the values of the WHO code. I think it's important to also note when people think about the WHO code, they think about some of these controversies around infant formula marketing. There is a tendency to say, well, don't we need formula? And really, the issue isn't about whether or not it is needed. The issue is around how it is marketed and what is the harm that is associated with that marketing. So with the WHO code, there are a number of human rights instruments that really form the architecture of the code. The first is the elimination of discrimination of all forms of women to protect them against human rights abuses on the basis of their gender. There's also the maternity protection, so that women should not be discriminated against for being pregnant in the workplace, or for breastfeeding or pumping their milk in the workplace. And then also the UN Convention on the Rights of the Child, in which breastfeeding is defined as a human right for both mothers and babies, and that they deserve protection from predatory marketing. And so this kind of advocacy for a more ethical way of dealing with breast milk substitutes globally has been controversial. In 2018, many of you may remember the headlines around how the WHO, the United States, not only didn't support the new resolution to actually strengthen the language and sort of in-country protections for the United States around adopting some of these aspects of the code here, and not just, it wasn't that they just didn't adopt it, it was that the administration and the representatives of the United States at that time actively undermined the passing of the resolution by introducing economic sanctions and sort of bullying tactics for other countries who were preparing to put forth this resolution. So you see the United States protecting its economic interests. Right now, the formula industry is estimated to be about a $55 billion industry per year, with the United States having one of the largest markets. We are also one of the largest producers of, excuse me, of infant formula that is marketed around the world. And some reports estimate that there's around a $7 billion investment in the marketing of these products alone. In the recent Lancet breastfeeding series that was produced, they have a really nice analysis of the sort of the marketing playbook of formula companies that they use. And in this model discusses some of them. And really, it follows all of the same things that we've heard: market capturing the science, influencing consumers in very specific ways. So as I mentioned, there's an enormous amount. There's more money invested in the marketing of commercial infant formula than there is in the preparations or the making of the formula. And certainly, as we saw recently with the infant formula shortage crisis and the contamination issues, less than they invest in sort of guiding the safety of those products. They also engage in, excuse me, cultivating loyal long-term customers. So not only do we have infant formulas, we have formulas for stage formulas for infants that are from birth to 6 months. There are also formulas that are now being developed and marketed for toddlers. There is also formula now being marketed for people who are pregnant. These are some examples of some of the marketing tactics that are used in the labeling and disinformation, just really segmenting customers and really trying to promote products that meet their needs. But this is all based on no science at all. There really aren't scientific backings for this claim. You all may have seen the headlines also about Nestle adding sugar to baby milk and cereals that are only exported to poor nations. So there is some really unethical dimensions of the marketing as well. And so really thinking about after all of these years and all of these global movements to try to intervene, we see these marketing tactics really, especially in this industry, really adapting to the current market, using lots of digital tools and AI to inform how they make their decisions. We are really excited and interested to see how a market driven epidemics model may lead us to some new solutions. So I'll stop there. I know we're running short on time.
Thank you, Anjali. That was a great journey through a very, very sad dynamic that we've had. If anybody wonders if character matters, on that original vote at WHO, the guy from USAID who was supposed to vote against the infant formula breast code WHO resolution, he resigned. It was a high-level resignation. He couldn't get a job for 2 years. And when I talked with him 20 years later, he said that courageous decision to resign made his career. So, I mean, people can stand up. They may lose a battle, but the war is still winnable. So turning over to John Lowy, one thing that when Esther and I started this journey and sort of binge read or audio booked the tales of all sorts of different, what we now are calling market-driven epidemics, one of the striking things was the power of the legal profession. And so we're really fortunate to have John Lowy, the founder and president of the Global Action on Gun Violence, and he's been litigating and advocating for gun violence and winning cases and really looking out for how do you hold the industry accountable? How do you protect people who've been the innocent victims of gun violence? So, John, thanks for being here, and over to you.
Sure, thanks for having me. Um, I'm going to talk mostly about how legal action can be used to address MDEs. I guess briefly, I can touch on the fact that, in my view, firearms meet the definition of MDEs. There's widespread unhealthy use. There's almost 50,000 deaths in the US alone from guns, twice that for injuries, and guns are marketed in ways that purposefully hides their risks. In fact, guns are marketed as promoting safety when all studies show they reduce safety, that they increase risks. And certainly the gun industry actively resists mitigation efforts in all sorts of ways that I'll address when I talk about legal action. And my experience has all been dealing with the firearms industry harms that result from that, but I think there's lessons to other MDEs, and firearms, like some of these other MDEs, involves a very powerful industry, a politically powerful industry. And I think that's important because as a result of that political power, it is underregulated. In fact, I believe that in many ways, the gun industry, even though guns are probably the most dangerous consumer product on the market, in many ways, it's the least regulated consumer product on the market. Guns are the only consumer product that's exempt from federal product safety regulation. It's the only product that's exempt from certain types of civil liability. It's the only product or industry that's exempt from some Freedom of Information Act. There's restrictions on law enforcement to crack down on gun dealers that you don't find with any other aspect of law enforcement. Those create loopholes, gaps in regulation that allows for a lot of gun industry misconduct. And that misconduct is what leads to most gun deaths and injuries, in my view. And I'll talk about specifically, how that happens. For one, crime guns are supplied almost entirely by irresponsible, if not unlawful, gun industry practices. You have about 5% of gun dealers that sell about 90% of crime guns. And many of these dealers illegally sell guns or sell in obviously reckless practices where they sell bulk sales to obvious straw buyers. They do sales where there are indicators that the purchaser is a trafficker or straw buyer. And I've litigated many cases like this. One, two people walk into the gun store, guy picks out 12 guns, and the woman beside him fills out the paperwork and says she's the buyer. That's an obvious straw sale. Another case where someone bought 85 guns in a single purchase from a licensed gun dealer. Obviously, that's a trafficker, but the dealer did those deals because it made them money, and they didn't get into any trouble for doing those deals because it was quote unquote lawful. And manufacturers, for their standpoint, know who these bad dealers are, and they choose to supply them, again, because they profit from it. In fact, the Department of Justice back in 2000 told the gun industry, the gun manufacturers, that their practices were supplying the criminal market. They could stop that supply or reduce the supply by not supplying these dealers that sell all the crime guns. They should institute training for their dealers and safe sales practices. They didn't do any of that. And instead, they went to Congress to seek special protections from liability, and they've gotten away with that. So it's those practices that supply the criminal market. And because guns are uniquely exempt from product safety oversight, the industry can get away with being literally, in some cases, a century behind the times in safety devices. And their safety features would prevent many unintentional shootings of children, and also safety features that would make it much more difficult to transfer guns in the criminal market. If this were any other product, Consumer Product Safety Commission or some other entity would step in and say, you got to put in these safety features. They would allow lawful users to use a gun, but they would minimize these other risks. And again, because there's not that oversight, they can get away with selling these guns, which unnecessarily cause death and injury. And the importance of legal action is, when you have these huge gaps in regulation and policy, one way to get at that problem is outside of the political system through legal action on behalf of victims of these reckless, in some cases unlawful conduct. And by doing that, you can place a incentive on manufacturers and dealers to act more safely. And in some cases, you can even get injunctive relief, or a court can order the manufacturer or dealer to start selling guns and the safe way rather than the unsafe way. And that's what I've been doing for over 27 years now. And one response to that is because of the unique political clout of the gun industry, they were able to go to Congress and get some protection from civil liability that no other industry in the United States has. And so that makes it more difficult to hold them accountable than other industries. However, there are exceptions to that law, and I have a case actually on behalf of the government of Mexico, which maybe I'll talk about a little bit, but that involves that protection statute, which is going to be before the Supreme Court. In fact, the court's going to hear argument in just a couple of weeks, March 4th, and that'll be the first time the Supreme Court has considered this, any issue actually of gun industry liability. But in my experience, while Congress has, for the most part, not taken any positive action on gun violence over the past 25 years or so, with a couple of exceptions, but for the most part, Congress has done the reverse and taken actions to make gun violence a bigger problem. You can make a difference through legal action, and in my cases there have been dealers. We've got to agree to institute screening practices to detect and stop sales to straw buyers, distributors instituting reforms as well. And there's generally also just a change in these incentives where everyone sort of feels that if they decide to sell 85 guns, for example, to the obvious trafficker, it's not going to be all profit. They may have to pay, and therefore they may not make that uh, that sale. So, and we're seeing obviously with opioids, we've seen it with tobacco and others, where legal action has often led the way to policy reforms where policymakers in Congress have lagged.
Great. Thank you, John. That was an amazing run through of the range of things that can be done with the firearm example. It's tricky. Let me ask everybody on the panel to just rejoin, unmute video. And I think we've got one question, which we'll start with Anjali to be able to answer on infant formula and all. And then let me just give each of the panelists kind of one final bite at the apple for what you think would be useful to share based on this conversation and your own perspective and role in this whole area. Anjali?
Sure, I appreciate the question. The issue around the ethical marketing has to be considered separately from the use of the product. So we're not really, this conversation isn't really about what do people need formula or not. There has always been a need for formula, which is why the product was created in the first place. What we're really trying to do is take the ethical considerations around the marketing and look at how it has been done in very unscrupulous ways to increase the profit of the companies without considering sort of the safety and the harms that it might be perpetuating. So yes, formula is a product that can be safe if you live in a place where there's clean water. You have soap, and you have everything that you need to prepare the formula properly and feed it to your infants. There are also specialty formulas that are designed specifically for infants with particular needs. However, you have an example of formula companies actually being on the boards that create the guidelines to do the science to understand cow's milk allergies. And then they create those guidelines and integrate that into how they are going to market particular formulas that say they're hypoallergenic, or they or doing something that is actually not scientifically, hasn't been evaluated through a clinical trial. And so those claims are being used to generate a little more trust in the products than they deserve. So that's one thing. Formulas in babies and older children with medical needs, that may be true, but these so all formulas shouldn't be staged. That the newborn formula actually has the most nutrition, and so it's the safest nutrition for all infants birth to 6 years of age. Not talking about specialized or hypoallergenic formulas, which are a medical necessity and usually only available through prescription. Those obviously are things that are needed. However, we see an expansion of the markets of these specialized formulas being used to sort of promote the idea that more babies in the general population will need these specialized formulas than they actually do. Toddler milks are unscientifically based. They're full of lots of sugars, and they're marketed as sort of a follow-on. And this is how we get the long-term devotion and loyalty to the companies. And again, some of these formulas for people that are marketed during pregnancy are designed to keep them loyal customers to that particular brand of formula during pregnancy, during lactation, and throughout toddler and adult childhood. In the vast majority of the world, these formulas actually lead to an excess of 800,000 deaths per year. And that includes maternal deaths from breast cancer, diabetes, and cardiovascular disease, and not to mention all of the newborn and young infant deaths. So while in the United States, we can say most people have access to the resources they need to keep formula preparation safe. That is not true for the vast majority of the world in which these products are marketed.
Wow. Ooh, okay. Well, it's challenging situation, but part of the role here is to figure out what'll bend the curve sustainably and significantly. Esther, quick, we're getting short, so quick bite from you, and then we'll move down the line.
Sounds good. One of the things that I think has been so key in looking at the times when mitigation did effectively happen and consumption was turned around was that an authoritative public health voice with clear messaging is incredibly necessary. And I think we have a current trend of distrust in government, distrust in public health, and also maybe a gap between how to effectively communicate science to people when college degrees are very expensive. Getting educated is very expensive. Understanding science is not easy for someone who hasn't spent years training in that discipline. So I think one of the areas that might not be as specific as dealing with MDEs, but trying to regain the trust of the public, create good relations between scientific foundations, scientific groups, and people that have never been educated in science is pretty much key, because without authoritative public health trusted communications, a lot of these public health and MDE issues could probably still be on the rise. So that's one issue that's like maybe even one scope outside of what we were discussing, but we need to start building trust back between government and the people.
Okay. Yeah. Critical issue. And lots of really promising effort on that too. Anna? Oh, unmute.
I want to echo what Anjali said about this being a problem of expanding the market beyond the evidence. So just like there's a time and a place for baby formula, there's clearly the time and a place for prescribing opioids, and they are evidence-based treatment for pain short term. The problem is when the commercial entities expand the market beyond what we have scientific evidence to support. The same thing with cannabis. There's pretty good evidence for cannabis working for pain very short term, on the order of 2 weeks, but there's no reliable evidence that cannabis helps any mental health disorder despite the marketing. And there's certainly no evidence that cannabis helps pain beyond 2 weeks, and probably like opioids, people develop tolerance, it stops working, you need more and more. With psychedelics, again, I wouldn't want people to take home the message that there's no role for psychedelics in the treatment of mental health conditions, but I do want them to take home the message that we don't yet have reliable evidence. For example, the recent MDMA for PTSD study was rejected by the FDA because it was bad evidence. So maybe there's a role for MDMA in the treatment of PTSD, but we need more studies, we need unbiased studies, we need more evidence. Also, I want to just emphasize that Anjali touched on, I think, inadvertently, a very important, not inadvertently, but didn't have time to probably highlight what I think is a very important part of this is the racial part of this, and the ways in which many of these epidemics are targeting the poor, targeting the disenfranchised, targeting brown and black people. The opioid epidemic is interesting because initially it actually targeted people who had health insurance and saw doctors, which was primarily whiter, richer people. But in the latter phases of the epidemic, the steepest rises that we saw in opioid addiction and overdose deaths were and are now in Black and brown people. So I think that's really important. And then, Esther, just want to say the trust in science is so important, but science has been horribly misused. We're not told what the real evidence is. The evidence is commonly distorted by our government as well as by commercial entities. So of course, people are mistrustful.
Maybe in a future, I'll return to that topic for a Think Global. John, what are your final thoughts?
Sure. Just two quick ones. I mean, one, similar to some of the other comments, I mean, my point is not that guns in and of themselves lead to the epidemic, but it's how guns are designed, marketed, that leads to this problem. And that's why, there are other countries that have significant gun ownership, and they don't really have a gun violence problem because they have sensible regulations and policies. And the US is really unique in the world, where you've got one making a lot of guns, most in the world, and at the same time having refused to enact the policies that virtually the rest of the world has enacted. And that leads to my second point, which is that U.S. gun policy is a global issue. It's not a domestic issue. It is no coincidence that 60% or more of the gun deaths in the world take place in the Americas. It's no coincidence that 9 or 10 of the top 10 gun death rates in the world are also in the Americas. I think many, if not most, of those guns come from the United States. In Mexico, 70 to 90% of their crime guns come from the US, illegally trafficked. Haiti, Jamaica, Canada, many of these countries have strong gun policies, but they're flooded by illegally trafficked US guns, and that's a result of US gun policy and US gun industry practices. So I do think it's important for us to recognize that this is not a legitimate domestic political choice by the US when it has these vast international effects.
Thank you, John. Just a couple of final words. First of all, thank you. Thank you for those that are still staying on. One of the foundations on this goal of asking the question, what does it take to get sustained significant reductions in unhealthy use? Healthy use is fine, unhealthy use. We look to find who succeeded. When you're talking to people about something that seems hopeless, if they've got no examples of somebody who's been able to tackle the problem, it's all theoretical. Coulda, shoulda, done but we really are looking, the projects going on now are looking at who succeeded and finding out how they succeeded. Just taking firearms, there is a stunning difference between the groups of states that have been the leaders taking their gun deaths steadily downhill over decades and other states that are going up. There are differences not just in the states, but in how people respond. So if you're interested in joining, we are continuing to pursue research opportunities where we're looking at concrete examples. And if you want more on the details of some of the things we've talked about, take a look at the website or at the PLOS Global Public Health. Thank you to Esther, to Ada, to Anjali, to John. Sorry for running over, but really appreciate your time. Great engagement. And Gavin, thank you for staying in.
Thanks. I'll